Hi, everybody. Welcome. My name is Kevin Sabet. I'm the president of SAM, and it's really an honor to welcome you really to this discussion. We're so honored to have two living giants in our field, in the field of mental health and addiction. They really both, especially to this audience, although we have a lot of new people too, which is great, don't need an introduction. But I'm going to give them a slight introduction and kind of talk about the way I see today going. So this is part of the series that we have that is sponsored by DARE. DARE, really interesting story. You know, when I first, many of us were acquainted with DARE as kids because we were DARE kids. I was not. But the first time I kind of heard the drug policy community talk about DARE was from the late, great Mark Kleiman, who, I did not agree with on everything, but I think on a lot of things we did agree. And he said once to Frontline PBS, there's a great Frontline PBS old show on the history of drug policy, which I recommend for everybody. And Mark said that, which I think is true, DARE is a wonderful tool for police community relations, particularly in poor neighborhoods. He said, getting poor kids to meet a police officer and getting a police officer to meet poor kids on a civil, friendly basis is a wonderful thing to do. Police officers love it, departments love it, neighborhoods love it, kids and parents love it. What he did say at the time, though, and this is about 20 years ago, is that it's not a complete drug prevention program. And there were a lot of problems. But one thing I really admired, having observed DARE over the years, was how they listened to their harshest critics. They didn't take the evaluation and just say, oh, this is bunk, this is wrong, this is biased. They actually went through it and said, frankly, for the mid 90s now, as we're now updating, and times have changed, at the time, they said, this actually, maybe there is something to this evaluation. How can we change? And they did that. They changed, and they completely redid their curriculum, although they, of course, still have officers interact, which, as Mark said, was a positive thing. And I'm just going to share my screen for a second. I was very encouraged to see the Scientific American with an article saying the new DARE program, the one that works, and it's really the new substance abuse curriculum they have. It's completely different from the past. I urge all of you to check out that article and really to see how, with their new evaluation from UNC, it is the only officer-led prevention education program that's been proven effective by, an independent multi-year evaluation. And what's interesting about it is that, it is, whether you like it or not, it's the most popular drug prevention program in the world by far in terms of reach. And the fact that they listened to their harshest critics and went to them to redesign the new curriculum, I think just speaks volumes. So in that regard, we're sort of honored to be associated with them and the great people of DARE. Coming to now to this webinar, this discussion, Patrick and Nora need no introduction, but as many of you know, Patrick is a close friend of mine. He was a former congressman over 20 years in Rhode Island. Was the co-founder of SAM and the honorary chair back when we started in January of 2013. And he's the founder of the Kennedy Forum and really the co-author of a wonderful book, A Common Struggle. I think many of us know and knew Patrick and got to know him in his days as a congressman as the lead sponsor of the Mental Health Parity and Addiction Equity Act. And that fight for coverage and equal coverage under the law and making companies, which are, making obscene amounts of money, healthcare companies, actually understand that the brain is a real part of the body and that they need to reimburse for these mental health and addiction services has been the cause of his life. And we are so proud to be associated with them. And related, the cause of his father's life, who was really one of the first US senators to take on big tobacco at a time when it was completely not popular to do so. It's kind of hard to think about the fact that we used to allow smoking in the Capitol and in restaurants and in airplanes, and the biggest lobbying outfits were all from big tobacco. At that time, when it was so unpopular, it was Teddy Kennedy who took those forces on. And I think really for us at SAM, is really an inspiration. We're both, Patrick and I, extremely honored to be joined by the longest serving director of the National Institute on Drug Abuse, which is a division of NIH, and that's, of course, Dr. Nora Volkow. NIDA, as you know, is by far the world's largest funder of research on all kinds of health aspects of drug use and addiction. And Dr. Volkow has been a friend of both Patrick and mine for a very long time. We've been around the world a few times together, speaking on these issues, and her leadership within the NIH to really raise addiction up as a health issue and to give it the care it deserves. Because, for an issue that is related to more illness and death than any other health issue, if you think about it, and more healthcare spending, it doesn't get the attention it deserves. And we are honored that Dr. Volkow has made herself so available to the public and to press from all angles to really talk about the importance of research and what we are learning and what science can tell us and how science can lead us to a better drug policy, especially now that we are facing just unprecedented numbers of those who are passing from the disease of addiction. So I'm going to turn this over to Patrick in a minute. I wanted to just introduce a few slides introducing folks to SAM and what we're really all about, and kind of why this is an issue for us, and why we're very concerned about the really the normalization of marijuana and really how this affects youth and in society. So SAM, as many of you know, evidence-based approach to policy. We really reject extremes on either side. We're led by a very prominent scientific advisory board. These are researchers that are on the IOM, that are part of the National Academy of Medicine, top institutions. Most of them receive a lot of funding from NIDA, which of course, as the grantee, that would be the case. And really one of the purposes of SAM was to make sure that our message didn't just stay within academic journals, but actually got to the people. And that's why we've been really led an aggressive press effort to get the simple messages out about today's marijuana. We are a nonprofit. We educate and promote health first policies, and we're proud to collaborate with different organizations, health organizations, business, law enforcement, treatment across the country. We really try and emphasize that from a policy point of view, which is not the full discussion of today, but I'm sure it'll come up. We like to emphasize that there are really three different issues that often get conflated: decriminalization, legalization, and the appropriate or inappropriate medicinal applications of marijuana or its components or its synthetics. And we think these issues often get conflated, and then we can't really have a productive conversation because we're all starting from different definitional points. And I think it's really important that we separate these issues. SAM does not believe in criminalizing individual users for using marijuana. We believe that if they have a problem with it, they should get help, and we should have evaluation systems to figure out whether they have a problem with it. And we should not be penalizing with criminal records, but we should also not be going towards a repeat of the disaster of the #1 public health disaster in the entire discussion of substance use, which would, of course, be the discussion on nicotine. Because when you look at tobacco, when you look at nicotine, kills more people than any drug ever did. And it was really led by a propaganda campaign that was about money and about making a lot of money. And we don't want to see that repeated for any drug. And we're very concerned about how that's might be sort of going down the path for marijuana. When we talk about marijuana, we don't talk about this. We don't talk about the old marijuana as much as we do the really new marijuana. So there's old marijuana, new marijuana, and the kinds of products that are out there on the state market. We absolutely agree that we need to research these products. We need to know much more about them because we don't know what 99% THC does in 20 years to somebody who's taking it 5 times a week. We just don't know that. And Dr. Volkow can correct me if I'm wrong when she speaks, but we don't know. We need to learn a lot more about these products. We need to learn a lot more about what's out there because what's out there is hurting a lot of people. I think Jonathan Calkins, who I really respect as kind of the biggest brain when it comes to policy analysis in this field. I really love his comparison when he talks about how we have a new kind of consumer today of marijuana. The average consumer of marijuana today if you want to compare it to the average consumer 20 years ago, it would be like comparing someone who drinks and it has caffeine from 33 Starbucks grande cappuccinos versus one 20-ounce bottle of Coca-Cola. That is the kind of orders of magnitude we are talking about when it comes to the amount of the average user and that heavy use that we have seen, that really a startling change of heavy users and the THC consumption. And I think that's a great analysis, a great analogy, I should say. And it's one that why we need to study this even more. Obviously very concerned that, again, as I said, big tobacco is big marijuana. It's the same kind of players, slightly different marketing. All the major tobacco companies are now involved in marijuana. They're involved in Capitol Hill. They're involved in think tanks. They're funding politicians. I mean, it's really our worst nightmare from what Patrick and I were talking about 10 years ago. We're seeing kind of unfold. But we also are seeing a pushback. We're seeing that, there's social injustice that gets perpetuated because it is the people with the fewest resources among us that suffer from the consequences of addiction the most. And so we've been heartened by the pushback in local communities on this industry. These are a couple of our heroes in Compton, California, who have essentially pushed back on, and won, by the way, on the marijuana industry. We're very disconcerted by the fact that we still have a major racial disparity in marijuana in every state that's legalized. We're very concerned that Hispanic and Asian arrests especially are going up. We're very concerned that the people making money from this industry, they look a lot more like me and Patrick than they look like anybody else. That is very, very concerning. This is not the promise of social equity. I invite everybody to read the Los Angeles Times series starting today on broken promises. And it's kind of weird to see the things you predicted, and not just me, but many other people, Patrick, people like Keith Humphreys, Nora, so many people predicted 10, 15 years ago, now being in the headlines as, oh my gosh, look at what's happening. Because whether it's about equity, which the Los Angeles Times is covering today, whether it's about the density of stores that are in poorer communities, which is happening. These are new studies that have been published about California, for example, on the minority targeting, whether it's about the illegal market, which is thriving in all of these states. Seeing the cover of political magazines saying that legalization has made it worse, the underground market. Again, it's mixed feelings because you don't want to be right about these things. You actually want to be proven wrong. And sadly, we haven't been. So as we see this happening, we see just a huge influx compared to 20, 30 years ago of regular users. We now have, according to NIDA, 15 million daily users of today's THC versus about 900,000, which was in the early 1990s. Huge difference, more than an order of magnitude, something we absolutely need to watch. And it's really following the addiction for profit model, because it doesn't take that many people to use your product daily to make a lot of money. And this industry knows that. They are targeting especially young adults, 18 to 25, very, very concerning before the brain is developed. They are targeting for this. And so we commend Dr. Volkow, we commend the Surgeon General, who has been very clear about what's going on and about how there is an addictive element, not for everybody, but for an appreciable minority of individual users. I think Debbie Hassan tells us 30% of annual users in her study from that was 5 years old now, showing cannabis use disorder. So that's 1 in 3. It's something we're very concerned about. It's something that we need to keep getting these messages out. The poison calls, the ER mentions. And in states that have legalized, we need better regulation. There's just no doubt about it. We fought for this very hard. We need limits on THC. We do not need the marijuana industry out there making rules for themselves. Why should they be sitting on those rulemaking bodies? It doesn't make sense. We do not need advertising. We do not allow tobacco advertising. Why in the world would we allow now marijuana advertising? And we need more of a science-based awareness campaign, not reefer madness, not overblowing the science. The science is scary enough. It speaks for itself. We need to get those messages out because parents have completely the wrong idea of what today's marijuana can do. If you haven't legalized as a state, we absolutely think you should remove criminal penalties. We don't want you going to prison. We don't want you having records, but we need to discourage overall use, just like we do with speed limits. Plenty of people will drive over the speed limit. that doesn't mean you get rid of them. It means that you make sure that you discourage speeding through speed limits and other ways. So there is a role here. It has to be done proportionally and appropriately. We're also very concerned about the driving issue, which we probably, I don't know how much we'll get into today, but it's a very complex issue, and it's something that we're very concerned about. We are also concerned about how this is linked to all drugs, how there is the huge overdose deaths. I'm sitting in British Columbia today. I'm in the epicenter in the Western Hemisphere of overdose deaths. Frankly, it makes West Virginia not look so bad when you look at what's happening in the downtown east side of Vancouver. And you see policies that are really of neglect. They're not helping users. We need to help them get the help that they need to lead a full life of recovery. That has to be the goal of everything we do. That has to be the goal of harm reduction. It has to be to get people into recovery. Patrick told me a great quote that I'll never forget, which is, we should meet people where they're at, but we shouldn't leave them where they're at. So Patrick, I'm sorry I stole that from you today. That is how we need to think about this. Otherwise, we're going down a path where we are allowing the sales, the use, and the promotion of drugs far, far more harmful, and I'll say it now, than marijuana, where we're talking fentanyl, we're talking other drugs. We have a lot of resources for you as I wrap up. You know that, lessons learned on legalization on our website, getting involved. There are a lot of things you can do to get involved, training events and advocacy, education, which is really what we're all about. And really, that's what I wanted to say. So without further ado, I'm going to throw this over to Patrick and Nora for our conversation. Thank you.
Thank you so much, Kevin, and thanks for your leadership on this. And what a powerful slide deck. It seems as though every year I see the new one. It just, the case, as you say, gets more and more persuasive, as if we needed to go into statistics and our common sense wouldn't tell us what we need to know anyway. And that is, if you expand the number of people who are using, and a certain small percentage of those people are going to have psychotic illnesses as a result, or addiction as a result, of just a small percent. But then if you magnify that total population exposed because of commercialization, then you're going to see an explosion of the number of people who are in need of care. And of course, I come from the vantage point of the parity law, which I had the honor of, as you said, writing when I was in Congress. And I've spent the last over a decade trying to get insurance companies and employers, who are also now responsible as fiduciaries to their employees' mental health, to get that system of care paid for in this country. And as of course we know now, post-COVID, as we're hopefully running into the end of this tale of long isolation and impact of COVID, you know, we're seeing the new end of COVID, which is the beginning of the legacy of the mental health impact of COVID, expressed even more on top of a pre-existing mental health and addiction crisis, even as we were going into COVID. Now that's, you know, we've added fuel to the fire, unfortunately, as we've seen through the statistics that you mentioned. But the reason today's conversation is so important is that, you know, we can have all the best kind of public health approaches in terms of treatment or expansion of coverage of treatment. But if on the other end, we are literally creating a whole new population with these illnesses, you know, at a time when we're trying to reduce the total burden of mental illness and addiction, I mean, that just doesn't make any sense at all. And I know that from all of our children's mental health crisis that Nora, your colleague, Dr. Vivek Murthy, has spoken very eloquently about, and has signaled as a Surgeon General emergency for this country in terms of children's mental health. I can't but think that all the kids with escalating anxiety, escalating depression, escalating trauma, and then of course the whole virtual and isolation that they're living in today, if they've got a pot shop down the street with gummy bears and elixirs and edibles, and which they don't even have to worry about their parents smelling the smoke, right? They can vape it and they can drink it and eat it. I mean, I shudder to think about the vulnerability of this next generation to the wide access that is commercially marketed to kids in a way that we saw tobacco being marketed as some kind of non-destructive product until we spent over a decade really getting all the documents from behind closed doors to prove otherwise. I just hope we don't have to repeat the failures of big tobacco and the failures of Purdue Pharma, where we learned what happens when you make this addiction a for-profit industry. That, Nora, you are doing all the basic science and research into the brain and the impact of some very beneficial of certain cannabinoids to helping with pain and seizure and other things. But you also are obviously seeing that science is not just in the microcosm. Science is in the public health impact. And your mandate is to fight on behalf of the country's overall mental health and addiction. And it's hard for me to think that you spend your whole time trying to get a better therapy when in fact the solution to actually reducing the burden of this could be if we could just shut off the expansion of this through a huge commercial enterprise that is funded all based upon how many new people they can get to use a product that we know a certain percentage of those people will end up either addicted or affected very seriously in terms of their mental illness. So with that as a broad opening, Nora, if you would, I'd love to hear about not the kind of the biology of neuroscience, which you've spent your life focusing on in your institute, but moreover, kind of the science of public health as it relates to addiction, because I know that translational research is also part of the domain of NIDA.
I know, Patrick, thanks very much. And Kevin, thanks very much for having me here. And absolutely. And I think that we all have been sensitized to how important public health is with COVID, and how science by itself, when you're just focusing on the products, is not sufficient. So we have pretty remarkable vaccines, and yet we never expected that there would be such a rejection of those vaccines. So to the extent that we can understand the impact of an intervention at the public level and why it can be transferred in some instances and not on others, is crucial for us to be successful. And I've been very sensitized to also as it relates to what is it that we can do to improve the outcomes of everyone as it relates to drug use, and starting with people that are addicted. How do we penetrate and ensure that they have access to the treatments that will allow them to have recovery? But even more importantly, Patrick, what you're saying, because it's something that we tend to relegate to the back where it should be at the front, is how do we prevent the initiation into the trajectory of drug taking and in addiction? And I, as you were speaking about it, in terms of the challenges, particularly for young people during the COVID pandemic, that we know that actually through surveys to evaluation, there has been a significant increase in anxiety and depression on teenagers during the COVID period. And the changes that are happening are actually complex, but I think that we need to be very much in our toes, because you're absolutely right. When you have one of the factors that increases your vulnerability for drug taking as a teenager is anxiety and depression and isolation. And the COVID pandemic has isolated all of us. Interestingly, what we've observed during the COVID pandemic is across schools in the United States, the prevalence of drug use has gone down during the COVID pandemic, which is likely very much reflects the fact that kids don't have the opportunity to interact with others. And drug taking at that stage is a peer pressure behavior. But what is underlying is that when we go back to a normal interaction, the anxiety associated with what they have lived and everything that they've lost in the process is going to make them much more vulnerable. So while right now we've seen a decrease, this is likely to be related to the circumstances of not having the opportunity to be in schools or in groups. And the other thing that I am very worried about, and again, right now we're not seeing it, is suicidality. So interestingly, suicides have gone down during the COVID pandemic, which to a certain extent could have been predicted if we look at data in the past, where you see a major challenge. You say, well, people are going to be more vulnerable for feeling despair. But the increase in suicide happens after you've actually controlled the main situation of stress. And when the attention shifts to other processes and the person may feel themselves isolated. And so I am concerned absolutely about what's going to happen to the new generation, these teenagers as we go back, that have been negatively affected educationally, that have higher levels of anxiety and depression, and that how are they going to be dealing with it? And I think that this is an element that is crucial. Now, let's jump also in terms of marijuana. How does this come into play at a stage in our country where, in a way, the states are legalizing marijuana, different processes. What is happening? This is making marijuana more available to everyone. And as Kevin was saying, there's no surprise, the rates of smoking marijuana have gone way up throughout the United States, highest among those that are 18 to 24 years of age. And as we see more and more people exposed to marijuana, as he was commenting, we're learning that yes, it's associated with adverse conditions, and not just medical. But for example, one of the areas that to me is of particular importance to understand is we're seeing a very strong association between marijuana exposure and suicidality. And this is why I'm bringing it forward. So people may take marijuana to try to escape a reality that is difficult for them. So they see it as a way out. But with repeated exposures, what they are doing actually is jeopardizing their ability to cope and making it worse. So when you are telling me what do I want to speak about public health and policy, I think that this is likely the most impactful thing that we can do in terms of creating policies and public health interventions that will ensure that the knowledge we already have, that cannabis exposure during adolescence is particularly detrimental. And I'm not going to be speaking about adults. It's particularly detrimental. So what is it that we can do to ensure that we protect kids and we protect young people? And also, what is it that we can do through policies that ensures that you actually got the parity law? Patrick, that's wonderful. But the problem is if you cannot access those treatment providers, it can be very good. And no one is going to, I mean, a very restricted number of people are going to receive the treatment that is needed. So I would strongly argue towards increasing and evaluating the systems that we currently have to ensure that they provide accessible treatment. And importantly, also policies too that cover for screening of mental illness, behavioral disorder, drug taking very early on, as early as you can. So not leave it towards the end when the symptoms are manifesting. So the screening component that you have also been speaking about, head up, not just head down, is something that we should actually implement, and insurance should be paying for it, the reimbursing physicians, and we should be educating parents. So this is the go around to tell you, yes, absolutely, public health is fundamental to addressing the crisis of drugs that we have in our country, including the overdose crisis, as well as the mental health crisis.
Thank you so much, Nora. You always take whatever I've said and make it sound really articulate because you frame it so beautifully, and it's really refreshing, I think, for everyone to listen about, you know, how impactful public policy can be. It just makes sense that, you know, we can't treat our way out of this, especially with increased demand for mental health and addiction at the same time as we have such a shortage of available providers. And then we're going to make this concoction even worse by adding a funnel of increased need that's going to come directly because of some policies over here that are going to increase the exposure. And then that's going to be jeopardized by the fact that the current, you know, environment that we're living in is only going to ramp up the use of those products because of the nature of the anxiety rates amongst young people today. So thank you for helping to connect all those dots. Let me ask about kind of the different marijuana. Kevin started at the beginning with the kind of old and the new. As you know, the big thing now is that some people think of marijuana and they think about the older, less potent forms of marijuana. Could you talk a little bit about kind of the character of this type of marijuana that we're seeing now in such concentrated forms, and the real questions that raises in terms of the impact on the brain, on the developing brain.
Yeah, no, and it is an important to note, because we all live, interpret things based on our experiences. So a lot of people smoke marijuana when they were teenagers and says, well, what was the big deal? And so that's why everybody says it's not your grandparents' marijuana or your parents' marijuana. The active ingredients of marijuana that makes you high, the reason why people use marijuana in recreational purposes, is because of THC. And THC actually stimulates reward centers in the brain, and basically it makes you feel relaxed and at ease, and it's a sense of well-being. So that's obviously everybody wants to feel like that. So this is the appeal of marijuana. The higher the content of THC, the stronger the properties of the marijuana. So, but because there is always a price in terms of how do you stimulate that reward system, when you are dealing with drugs that are very potent, the more potent the drug, the greater the likelihood that you're going to generate adaptations in that reward system. And that's why you can have rewards that basically natural rewards, but you never necessarily become compulsive about them. Sometimes you do, but it's much rarer. The higher the content of THC, the greater the likelihood that you will become addicted to the drug. But the other problem about it is, and now if you compare the drug now versus the drug that you have in 1999, so that's 22 years, the content of THC has gone up by at least 4-fold. And there are certain products that actually, so now average content is 13% of marijuana plants, whereas it was 4% in the past. Now, there are products that you can actually have THC content up to 30%. And then if you go further, you can now take electronic cigarettes and put a cartridge of THC that's basically 90% THC. Of course, some of that content is not going to be totally absorbed, but you get huge concentrations. And there you have opening up the door, not just that the THC will become more addictive on that level, but it is much more toxic. And so we are seeing a very significant rise in psychosis associated with the consumption of marijuana. And the higher the content of THC, the higher the likelihood of a psychotic episode. And any one of us taking one of these high content THC can become fully psychotic. It's not, we're questioning it. You can fully become psychotic. The question is how long lasting that psychosis is. I mean, it can be extremely scary, and you end up in the emergency room, hospitalized 24, 48 hours. And in some instances, those cases become chronic. And that's when you go into the diagnosis of schizophrenia or chronic psychosis. And those diseases are quite devastating. And obviously, as we see more and more high content cannabis, we're seeing more people ending up psychotic in emergency rooms. And there has always been this dialogue in the psychiatry world whether marijuana can produce schizophrenia, which is one of the most severe mental illnesses. And there are people that say that it just, it doesn't contribute. The associations reflect the fact that early on the stages of this disease, you were not feeling comfortable, so you were trying to auto-medicate. Others say, yes, there is an association, but you have to have the vulnerability. So you are vulnerable, just like a lot of the mental illnesses, there is a genetic component and there's an environmental component. The mixture of that genetic vulnerability with the environmental component, the taking of the drug, triggers the disease. And there's very much consensus that that is happening. But there's also increasing researchers that are coming up with data that we cannot just ignore, that in some instances you are triggering an episode that otherwise would have not happened. And because of there was actually investigators that were asking the question, well, if indeed marijuana can produce schizophrenia, and you are seeing increases in marijuana use all over the world, why is it that we're not seeing more cases of schizophrenia? And so the Danish, which have a very long track record of having electronic records for years of the whole population, recently did a study to look if that was the case. And they showed actually there was a fourfold increase in the cases from schizophrenia that were for which marijuana was responsible. So that's a fourfold increase that actually from 1999 to 2010. There's been a significant increase in the number of schizophrenia cases attributed to marijuana. And this is epidemiological data based on electronic health records. But again, we cannot ignore it when you start to see these associations. And we need to communicate this as when people are going to be using marijuana, that they be knowledgeable about what are the potential adverse effects of this drug.
Terrific.
If I can just, on that, Dr. Volkow, this is where it's really interesting because obviously, we talk about addiction and use disorder, but you're talking about, I think, sort of adverse reactions that can be triggered from maybe one-time use. And I want to, maybe you can clarify that. So for example, it's interesting that the person that helped edit one of my first books used to be part of sort of the marijuana movement in the 70s, believe it or not. He's had a change of heart and he hadn't used marijuana for 30 years. And then this is in California, and then someone gave him a muffin and he ate. I mean, he didn't think the muffin could do much, but he ate the whole muffin because after 2 minutes of a few bites, nothing happened. So he said, this tastes good. It's like chocolate flavored or something. So he ate it. And then he ended up in the hospital for about, I think, 2 days because of an acute psychotic episode. He had not ever used he hadn't used in 20 years. He was not a regular user. And that was actually the last time he used. You can also think about the context of driving, right? Where somebody who may not be a chronic user, hadn't used in a month or something, uses and is intoxicated and has some kind of crash or injury. So that points me, I guess, to the question of, it seems like there's even a possibility beyond the regular users, which we know the more you use, the more likely you're going to have a negative outcome. But beyond that, there is the possibility, and even with adults, where using it once, depending on the product and who you are and your body, you could have a very adverse reaction. I mean, is that, I kind of present that as a question. Like, do you think that's, do you agree with that? Do you understand, does that make sense at all? Because we get questions like that from adults even now, much more than kids.
Yeah, no, absolutely. The answer is yes. You can, if you get a high content THC product, you can become psychotic on the first time you take it. And these are actually, people have reported that. And more frequently with the edibles, because edibles are favored by people that actually don't necessarily are regular users. And when you take an edible, the absorption takes much longer. So you take this edible and 40 minutes pass, 50 minutes pass, and nothing happens. So then they take another bite and they take another bite, and there is a cumulative effect, and then it hits them and they end up in the emergency room. Usually those events are short lasting, 24, 48 hours. But they can be extremely scary. And so there is no doubt about it. And the higher the content of THC that the person ingests, the more the risk of having one of these acute psychotic episodes.
Yeah. It's interesting because, again, we talk a lot, and I talk a lot about the regular, the heavy users. Obviously, that's where I think a lot of our attention should be, but it's for a lot of people, it's kind of eye-opening that it's not just about that. It's about, these occasional use with some of this stuff. I wanted to ask a question about, and it was actually sent in from somebody, really since this whole legalization movement has taken off in the last 20 years, obviously we've seen the increases that we talked about in use. We've seen mixed results across the country so far. Again, John Calkins tells me and others, you have to wait 25 years to fully understand the picture. And I completely agree. You can't say there's a final verdict now, especially with regards to sort of youth prevalence over time, because if you're a young person growing up in prohibition and you've been told this is not good, you may not just go use it tomorrow if it's legalized. I mean, but it takes time. Some of those sort of to erode those maybe anti-drug attitudes take some time. But I have seen California studies about youth from their survey. I've seen some Oregon studies. Can't remember who wrote them in peer-reviewed journals. We've seen, I think, Maggie Serda's study about 25% increase in cannabis use disorder among youth in legalized states, whereas we haven't seen that in other states. What are your thoughts kind of just about some of these trends? Again, they're not in all states, with regards to sort of youth prevalence and really in the context of this sort of acceptance and normalization.
Well, where we have the most data is for adolescents, because we are doing the Monitoring the Future survey, and we have looked at the trends and the prevalences of marijuana use among states that are legalized versus not for teenagers. And overall, we have not been able to see large differences in terms of prevalence, or there's some favoring of consumption, higher rates of consumptions with edibles than in states that have not legalized it. So, but the effects are not large. And one of the things that also has certainly surprised me, because I didn't expect it, is the rate overall, the prevalence rates of marijuana use among teenagers have been stable despite the legalization in many states. One of the concerns, though, is in this type of survey, we are actually not properly monitoring the overall frequency of daily use among teenagers seems to be creeping up, which is one area of concern. But we have no way of monitoring the doses that these kids may be taking. So one of the things that we initiated to try to address this gap is we're asking for all researchers that come to NIDA with grants, asking for grants to study the effects of marijuana, that they use a standard dose so that they transfer whatever. So I say, a person says, well, I'm taking marijuana twice a day. Well, the standard dose is 5 milligrams. So how many standard doses are you taking a day? To try to also help us grasp beyond just these indicators that is once a year, once in a lifetime, or daily, that really don't give us a good sense of what's happening out there with teenagers. That's not the case for 18 or older, where you see a very significant rise in consumption of marijuana. And among teenagers, what we have seen, and this was something that was of great concern, was the vaping. Vaping just shot up, and that included vaping for THC. So vaping for THC almost doubled between 2017 and 2019 among teenagers in the United States. Mm-hmm. So we're also seeing that change on the way that teenagers are consuming THC cannabis products.
Yeah, I think these systems of data, I mean, we're seeing, you're exactly right. And we saw the announcement, which we supported, the standard NIDA standard for measurement of 5 milligrams, I believe, for research. It's tough because, we have the vaping, which we only started capturing recently from a data point of view. You have the 12th grade daily use, I think, in Monitoring the Future, just overall, as you said, going up. But then, you look at other states, it's stable, it's down. It's depending on the year, depending on the kind, depending on the type, it can generally be a tougher, I think, picture. Of course, when you look at ER mentions, hospital mentions, treatment entry, some of that stuff, I think it becomes clearer. But depending on the state, I think it matters. I've been fascinated with the studies. Again, a lot of them NIDA funded. I think all of them partially NIDA funded, on the prevalence of dispensaries and stores in local communities, and advertising, and how that affects young people's use and attitudes in that sort of very particular neighborhood. I think have been really interesting. So I commend that kind of research to be done, because I think it can help paint a picture.
And Kevin, another area that I think it's also very important to keep our eye on is actually pregnant women.
Yeah.
Because the prevalence of marijuana use during pregnancy has tripled or quadrupled over 2 decades. And that is very worrisome, obviously, because to start with, we know already that there are adverse effects of smoking marijuana on delivery. I mean, the babies are born premature, they are actually a lower weight, lower height. And then the question that it's even more fundamental than that is how does that exposure during pregnancy affect the neurodevelopment of their brains? Are we jeopardizing their trajectories? And that is, for us, crucial. And to see that something like 6% of our pregnant women were smoking marijuana gives you an idea that this is actually something that could have downstream very negative effects. So it is, again, and here you have a pattern of consumption that is not only going to affect the woman herself, but is going to negatively impact on the newborn.
Yeah, let me just jump in. And my family, as you know, my Aunt Eunice is the name on one of your colleague institutes, the National Institute on Children and Human Development is named after my Aunt Eunice because of her work on developmentally disabled issues. And it's tragic that, the fetal alcohol syndrome is one of the principal causes of intellectual disability. Of course, is entirely preventable. But of course, with the liquor industry, we've seen over the decades a loosening of regulations on advertising and the like around media, commercial advertising, as well as, we've seen these children's flavored alcohol drinks and sodas and things, so the hard lemonades and like, and we've seen that explode. And the reason I mention that, even though we're talking about marijuana, is that this shows how difficult it is to get the genie back in the bottle once you've, opened this Pandora's box. And people can say all they want with, oh, well, we'll do the regulation, we'll put a clamp and we'll protect kids. That's not been the case in alcohol. And I guarantee you it's not going to be the case here when this multi-billion-dollar industry grows exponentially to try to get public health protected against a commercial enterprise with billions and billions behind it. I can tell you, having been in Washington with the number of lobbyists for the liquor industry, if that becomes true with the marijuana industry, there's just no chance public health is going to be protected. And we've seen the impact of fetal alcohol syndrome. As you said, I can't imagine what the future impact is going to be of this exposure in utero to marijuana because of the de-risking of its use, frankly.
Yeah, no, and as you were speaking, Patrick, the other issue that is so very tragic about allowing these decisions of access to these drugs broadly to basically a profit organization. I mean, it's driven by greed. The more people use the drug, the more people use it frequently, the more money they make. Is that ultimately we see that this negatively affecting groups that are the most vulnerable. So individuals that are already at higher risk because they basically have low education, low income, underrepresented groups, for example, are some of the ones that are suffering the most because they don't have the level of alternatives and support systems that others have and can let them to buffer. So teenagers that get drop out of school that are like the ones that are more likely to go downstream in a cascade of effects that's going to lead them to take drugs as a way to be rebellious, to have an identity. And then that just basically opens up a door of negative outcomes. So it is very unfortunate. And I think that it was the notion that, yes, we came from a perspective that criminalization has created a system that allows a structural racism to be implemented. You can control people, and that's a horrible policy, this criminalization. And that actually opens up our eyes that, well, yes, we need to change that. But at the same time, that does not mean that liberalizing and making the drugs available, widely available, with no counter messaging to actually the advertisement that's coming on, is going to make the people very vulnerable. You are also expanding the health disparities and overall social and economic differences that already exist. So I am also concerned that we keep an eye and that we monitor the consequences by group and background, so that they cannot be just put under the rug and saying, this stops criminalizing. We shouldn't be started by criminalizing. That's a no-goer. You don't put people in prison because they are taking drugs. But that does not justify that then, okay, let's everyone make it widely available for everybody, and we're not responding. I mean, everybody is free to choose what they want. I think it is, with the COVID pandemic, we've also become aware that we all have also a responsibility towards our communities.
Well, I love that you're disaggregating the data, because I do think, to your point, that it's going to show how disproportionate the impact of this advertising is going to be. Just like we've seen liquor stores 13 times more likely to be in Black and brown communities than in white communities, we're clearly seeing this repeat itself with the marijuana industry. I know in my community, Brigantine, to 90% white, we banned any stores in Brigantine. My neighboring communities of Atlantic City and Pleasantville, which are majority African American, there's no such pushback, because the industry has so much influence and power in a community which is so disenfranchised and economically challenged, that it's going to be the kids growing up in those neighborhoods are going to have to contend with a corner store selling this stuff everywhere when they get off the bus. Whereas in my neighborhood, thankfully, my kids don't have to walk past that. Now, why is that fair? My kids get an extra little shot in life, but the kids just across town don't. That's an injustice that disaggregating this data on an effect is going to really help us show that those who say there's some social justice impetus for a commercialization are really disingenuous when they make that case. Kevin?
Yeah, no, and I think that we need to bring them up. I mean, sort of show the data to say that this is not the case. This is just an argument to sell their product. So yes, and that's the purpose of getting data, so people can look at it and see, and not, it's not just my perception, this is what we know from collection of information.
Yeah, as we kind of wrap up, I wanted to just a little bit, because it can also preview future discussions, because I think this is very helpful. You mentioned sort of this issue of criminalization. Obviously, we don't criminalize people with diseases, biobehavioral disorders. I have a hard time meeting law enforcement who say that people with a substance use disorder, should be put in prison, and that's who they're arresting. I've actually have not met anybody who said that. Obviously, there are laws in the books, and drug policy needs to be constantly looked at and reviewed. But I think what the issue is we need to disaggregate here is that a lot of advocates of, let's say, drug decriminalization, kind of like what happened in Oregon. Oregon recently passed the decriminalization law. It basically says you have $100 fine, although I think they just got rid of that. So basically there's no anything, but you can call a phone number, and, if you get treatment, great, but also you don't have to get treatment. You just have to call the number. And if you don't call the number, there's no follow-up. So there's sort of that shade, and there's no extra treatment, by the way. There was no funding for treatment, increased funding when they passed that law. So there's kind of that shade of decriminalization, which I think is very different than another shade, which might be one that brings in drug courts, or, because a lot of people, as we know, they are committing crimes, but they also have a substance use disorder, in addition to and it's probably connected to the reason they're shoplifting or committing some crimes. And so rather than just lock them up in prison for their shoplifting, what can we do to integrate treatment within that system? For example, drug courts. So maybe, Nora, if you don't mind, because I think when people hear decriminalization, it's such a loaded word. And again, in Oregon, it means something. To other groups, it actually is a ruse for full legalization of all drugs with marketing, and they just use those terms interchangeably. For others, like myself, it means more of not criminalizing people with substance use disorder, but also understanding the role of how to integrate criminal justice and public health in an equitable way and in a way that gets people treatment. But also, we're not talking about dealers or, in that way. So maybe, I don't know if you have any, this was not about marijuana, but you mentioned it, and my drug policy mind is curious to pick your brain and go a little bit further on that, sort of the different shades and kind of which shade makes sense. The one that integrates treatment, the one that, like Oregon, that just says, goodbye, you have a problem, we hope you get help, but there's no follow-up. Because obviously this is a disease of denial, right? Addiction.
So let me just tell you, Kevin, my experience, most of the people I'm in recovery with, a lot of them came into recovery because of police officers that brought them in, and they wouldn't be sober or alive today if it weren't for those, as we say, angels in a uniform with a badge that came and saved them. Maybe, Nora, talk about this in the context of contingency management, because I think that is the big move in terms of science that NIDA has sponsored that shows that there is an element of contingency effect that actually helps people get on the road to recovery if deployed effectively.
Yeah, no, and I think, I mean, it's starting by the question posed by Kevin, absolutely. We have, when I say we have a responsibility to our communities, is when you are, as you're changing the pattern of how you address drugs in our country and people taking drugs, you need to provide treatment. And that's something that we have failed on doing at the level that would be beneficial. And so that starts not just for providing treatment for those that are severely addicted, but very importantly, to provide support systems for those that are starting early in the initiation of the substance use disorder process. We need to provide them with treatment that goes sine qua non. So just to say, okay, we're going to liberalize everything, drugs are going to be widely available, and not provide the support for those people under those conditions, I think it's actually quite irresponsible. As it relates to Patrick's question about what is the value of contingency, and I like to think a lot about contingency management, in which you actually, the simpler way of translating it is as an intervention, you get a certain reward if you're able to actually, for example, participate in treatment, and the longer you participate, the greater the contingency that you're getting. But at the essence of the contingency management, what the lesson to me is that it is the notion that we need reinforcers, and people that are addicted actually become exposed to reinforcers that are non-drug related less and less. It's harder for them to get any reinforcer from other things. So establishing the importance of alternative stimuli that can be reinforcing is crucial. So in contingency management, you do it by having someone, okay, you can give them money or a chance to go to a nice place. But it's also, as I think about contingency management, an important aspect of reinforcer is all of us. I think that the value of social interactions is crucial, and I always highlight it. And social interactions can be positive, or social interactions can be very negative. So to the extent that we stigmatize and decriminalize, those social interactions are very, very negative, and it increases your vulnerability for drug taking and for relapse. To the extent that those are interactions are positive reinforcing, you actually, in a way, have a much more powerful sort of additional contingency management intervention. And I want to end there, because I do have to jump into another meeting, but just to say that as we're discussing the issue of substance use and how Patrick asked me, we need to see this as a public health, and that the most consequential things that we can do are through policies. And we know sufficiently right now to design policies that can be implemented. We need to have, as everyone says, the will to do it and the resources to support what's necessary, including, for example, access to treatment to those that need it.
Great. Well, we want to thank you, Dr. Volkow. I want to thank Congressman Patrick Kennedy for this lively discussion to be continued. We could go on for hours. Really, your leadership means so much to us, Dr. Volkow, and sitting there with the Institute directors, Dr. Fauci, so many others talking about this issue, which has been elevated, mental health and addiction during this trying time in our country and world, really means the world to all of us. So thank you so much. I want to thank everybody who joined us today, and until next time, farewell.
Thanks for having me.
Nora. Thanks, Kevin.
Thanks, Patrick. Thanks. Bye, Kevin.
Bye.
Have a good weekend.
Likewise.